Thank you for kind introduction, Chairman. I'm Sohee Lee from Yonsei University, Seoul, Korea. Today, my presentation will be about the surgical completeness of robotic thyroidectomy. This study is a prospective comparison of robotic versus conventional open thyroidectomy in papillary thyroid cancer patients. The conventional open thyroidectomy is the most safe and effective surgical procedure in thyroid gland. However, it leaves a noticeable scar in a highly visible area, and many people was pressed by conspicuous neck scar for a long time. Transaxillary robotic thyroidectomy have achieved an excellent cosmesis, and its short-term outcome was comparable with conventional open thyroidectomy in low-risk PTC patient. However, the application of new technique in cancer therapy should assure oncologic safety. In this regard, robotic thyroidectomy lacked definite evidence of recurrence and survival rate. Therefore, we assess the oncologic effectiveness of robotic thyroidectomy in terms of surgical completeness by comparing with conventional open method. The study population included low-risk PTC patients who required low-dose radioactive iodine ablation, including T1 to T3 and or N0 and N1A. Eligible criteria was age over 20 years, well-differentiated PTC patient, and complete surgical resection without residual tumor and no abnormal uptake outside thyroid bed during the first ablation. Total 102 PTC patients who underwent first-time total thyroidectomy were prospectively enrolled. Of these, 51 patients underwent open and 51 underwent robotic method. The surgical extent was determined according to ATA guideline, and therapeutic or prophylactic CCND was performed in all patients. Of enrolled patients, 8 robotic thyroidectomy patients were excluded because they did not complete whole body scan due to planning pregnancy or personal problems. The surgical completeness was compared by assessing the amount of remnant thyroid tissue, ablation success rate, extent of nodal dissection, and follow-up ultrasonography. Remnant thyroid tissue was measured by radioactive iodine uptake in whole body scan and serum TG level. The count ratio of thyroid bed to reference region, including brain and whole body area, quantitatively denote the amount of remnant thyroid tissue. Ablation success rate was defined as diagnostic scan was negative and or the stimulated TG level was less than 2 nanogram per milliliters. This is the clinical pathology characteristic of two groups. The mean age of robotic group was significantly younger. In terms of histopathology characteristic, there was no significant differences and regarding TNM, TNN stage was similar. However, stage 3 was more frequent in open group due to the different age spectrum. This showed the surgical completeness at the time of radioactive iodine ablation. The number of retrieved nodes during CCND and stimulated TG level was also similar in the two groups. However, the radioactive iodine uptake ratio at post-therapy scan was significantly higher in robotic group. This showed the completeness parameters after ablation. Both suppressed and stimulated serum TG was also similar between two groups. The radioactive iodine uptake ratio decreased to similar value after ablation in two groups. The ablation success rate did not significantly differ, and there were no abnormal ultrasonographic findings in first-year follow-up either group. In summary, robotic thyroidectomy can perform clean CCND and it leaves more thyroid remnant than open method. However, it is minimal and effectively ablated by 30 millicurie ablation. In conclusion, robotic thyroidectomy achieves similar surgical completeness with conventional open thyroidectomy and provide a feasible and safe surgical option for papillary thyroid cancer patients. Thank you for your attention.
Questions? I would like to ask this. most of the patients who had robotic, did they have to pay? Is there a patient selection because those who are having robotic are paying for the procedure in your country, or is it available to everyone? And how is the decision is made? Who's going to have open? Who's going to have robotic? Just the selection criteria. How do they decide?
The selection of surgical method is just according to the patient preference. The patient can do open or robotic both.
Okay.
Yes.
Professor Kushiri?
Can I ask why does the robotic procedure leave more thyroid tissue or why?
Because our robotic procedure is transaxillary and the unilateral approach. So the contralateral side approach is more difficult than open thyroidectomy, but the amount is very minimal and can ablate by low dose radioactive iodine ablation. So we think the robotic thyroidectomy is feasible and safe in oncologic safety.
So does it mean that the robotic procedure would be not suitable for more aggressive cancers of the thyroid?
I think in more advanced cancer, we should study about the completeness.
Yes. Yes.
I'm Jung, the co-author of this study, so I want to answer the question. Actually, this study, the patient, I think, is relatively earlier period of the robotic surgery. So we use just unilateral one single incision for especially for the total thyroidectomy. So we in early period we left just a little amount of the contralateral thyroid tissue to preserve part-out gland. But recently we can remove all of the tissue to be seen. And I think we extended our indication gradually from the very early stage cancer now to we can do the relatively higher stage aggressive cancer. So with the experience, we can extend more, so we can apply it to the more aggressive thyroid cancer.
Thank you very much. We should move on. Thank you.